Hello, and welcome to today's Lunch and Learn, Brain Tumors 101, What's New and What You Need to Know. I'm Tiffany Mason, NKC Health Cancer Center Executive. Thank you for joining us. Today we'll explore how advanced treatments and new technology are helping physicians care for patients after cancer has spread to the brain. We'll also look at how personalized approaches are improving outcomes and enhancing quality of life for those facing this diagnosis. Our speaker today is Dr. Reintjes Jr. from NKC Health Neurosurgery. Dr. Reintjes is board certified by the American Board of Neurological Surgery and earned his medical degree at the University of Missouri, Kansas City. He completed his residency at the University of South Florida and finished his training with a fellowship at the Swedish Neuroscience Institute. If you have any questions during the presentation, please submit them using the Q&A feature below. We will respond to them at the end of today's discussion. And now, please join me in welcoming Dr. Reintjes.
Thank you, Tiffany, and thank you for having me today.
You bet.
So today we're going to talk about brain tumors, and specifically we're going to talk about metastatic brain tumors. There has been a few things that have changed over the years, and the whole paradigm of metastatic disease to the brain has changed in the last decade or 2 decades. And so I thought it would be important to talk about. Also, Tiffany's a great host because the hospital has really put an emphasis on treating oncology patients here, and treating cancer patients, and brain tumors are an important part of that. So we're going to talk about kind of metastatic brain tumors 101, what's new, and what you as the audience needs to know. So thank you, Tiffany, for the introduction. My name is Dr. Reintjes Jr., and I have been practicing here for about 7 years, or since 2018. So our objectives today are to learn how brain metastases, and we often call them brain mets for short, how they happen and what they mean for patients in today's oncology environment. We're going to talk about when and why surgery may be helpful for certain brain metastatic disease. We are going to explore new ways that we treat brain metastatic disease, including surgery and radiation. And we are also going to talk about the latest treatments, giving patients options and giving patients hope. And one thing I mentioned is metastatic disease to the brain is a much different disease now than it was several decades ago. Historically, brain metastasis has been a very poor prognosis, but with new technologies, immunotherapies, and radiation, it is more treatable and becoming more of a chronic disease than ever. So our agenda today is we are going to talk about the epidemiology of brain metastasis. We'll talk about treatment techniques and prognosis, and then I'll go over a few cases that we have treated here at the hospital, and then finally we will wrap it up with conclusion and some questions. So a brain metastasis occurs when cancer cells spread from another part of the body to the brain. So typically what will happen is the cancer cell will go into the bloodstream and go to the brain. The brain receives about 30% of all the cardiac output. So all of the blood that the heart pumps to the body, 30% of it goes to the brain. So you can see that metastatic disease to the brain is very common because the brain gets so much blood flow for obvious reasons. The metastatic brain tumors are the most common type of malignant brain cancer. Now, brain metastasis is not the most common brain tumor. There are lots of other brain tumors which are benign or not cancer, but brain metastasis are the most common brain cancer. The most common sites, and we'll see in the next slide, come from the lung and the breast. There are about 170,000 people affected in the U.S. every year with a brain metastasis, or that live with a brain metastasis. Going further, about 8 to 15 people out of every 100,000 are diagnosed with a metastatic tumor to the brain from another part of the body. Improved technology in imaging and screening have led to an increased diagnosis of cancer patients living with a brain metastasis. So typically when a patient has cancer in their lung or their breast, they will get scans of their brain, and a lot of those scans pick up small tumors that are really undetectable anywhere else, any other way. And so what that allows us to do is to treat those cancers and metastatic tumors earlier and increase survival rates. Older studies suggest that up to 25% of all patients with certain lung tumors or breast cancer or melanoma get a metastatic tumor to the brain. But the true incidence is unknown. I think in recent studies, in recent times, the incidence is actually higher than 25%, and that goes back to the increased detection. Sometimes patients can have a metastatic disease, a metastatic tumor that is the original diagnosis, so they don't have any evidence of a lung tumor or a breast tumor, but actually they have a cancer in their lung that has already spread to their brain, and that is because the brain receives so much blood from the heart. And about 25 to 45% of patients who get a brain metastasis or brain lesion will have one lesion with cancer elsewhere in the body. And of all the patients that get a metastatic tumor to the brain, about 30% will have more than one tumor. And the number of tumors can vary significantly between and that is due to several factors. One of the factors is the type of cancer that they have, also how advanced the disease is. And again, these numbers can vary based on detection methods. And the numbers are always changing, and we're always detecting newer and newer tumors in the brain. So this slide really shows, and I want you to focus on the pie chart here, and I'll talk about it a little bit, but it tells us what kind of cancers are most commonly going to the brain. We know that of all brain metastasis, about 50% of those are from the lung. The next most common tumor to go to the brain would be breast cancer, followed by melanoma. And some of the other cancers that we see, but less commonly, are kidney cancer, and that's called renal cell carcinoma, or colon cancer. And then there are a few cancers are undetected, or we don't know where they came from because they're so the cancers are so poorly differentiated, so we don't know where they came from. But that's pretty uncommon. The most common are certainly the lung, the breast, and then certainly melanoma. So we're going to go over a few treatment techniques, and today I'm going to focus on surgery and radiation. The other big treatment technique for cancer is immunotherapy or chemotherapy, but I'm not going to talk about that today. I think we have another expert, Dr. Fangman, who talked about oncology care, but we'll talk about the role for surgery and for radiation for the brain metastasis. So the goal of surgery is to remove the tumor and relieve the symptoms and improve outcomes for patients. Oftentimes when a tumor goes to the brain, it has significant surrounding swelling or edema in the brain, and oftentimes that swelling or edema is what causes the patient's symptoms. So in this picture on the bottom, this is an MRI of the brain, and we can see the brain here, but if we focus in right here, this round lesion that we say is enhancing, it has a white border, that is a brain tumor, and we can see around the tumor there's some dark areas, and that is the edema or swelling in the brain. And like I said, the edema is what typically causes the symptoms. On the right-hand side here, we actually have an intraoperative picture, and this is not my picture, but it shows the brain tissue right here, and it shows sometimes you can actually see the tumor on the surface of the brain, so it's actually very evident where it is. The patients after surgery tend to do well because if we're taking a patient to surgery, the tumor most likely is in an area of the brain that we can access safely, and oftentimes it is on the surface, such as seen as this picture. And so the brain tumor is actually not in the brain tissue itself, it's actually next to the brain tissue and displacing and moving the brain tissue out of the way. So when we remove it, the brain tissue can go back to normal and the swelling gets better. After surgery is when radiation comes in, and radiation is using a high energy beam to actually kill any remaining cancer cells. The two main types of radiation that we use for brain metastasis are whole brain radiation therapy or stereotactic surgery, and we'll talk a little bit more about that in a little bit. So over the years, we have evolved in surgically to be a lot more precise when removing tumors. Historically, when the field of neurosurgery was getting started 100 years ago, there was very poor ways to localize where a brain tumor is, and obviously you want to make as small of an incision as possible to disrupt as little normal tissue as possible. Over the last 50 years, we've developed framed guidance. So patients used to have to put on this, They used to have to put on this big frame and wear that into the operating room, and we don't have to do that anymore. Now we have something called frameless guidance, where we actually will register the patient and use the MRI and register the patient based off the surface landmarks of their face to create like a 3D image of the tumor in real time. And this is an example of a navigation wand that will help us localize the tumor so we can make a smaller incision and remove the tumor a lot safer. And like I said, it gives us the exact point where the tumor is on the surface of the skull, so when we make our incision and remove the bone, that the tumor is right there. As technology has evolved and with artificial intelligence, what we can also do is see, like we said before, this would be an example of a tumor. What happens is the tumor is pushing the normal brain tissue out of the way, and these different colors can show us where the actual brain fibers are being pushed. And so if the tumor is in a critical area, such as near the speech center or near the motor area or the motor cortex of the brain, we can actually find out where those fibers are and approach the tumor away from the important structures to remove it safer so the patient has the best outcome possible. This is an example of a imaging sequence called diffusion tensor imaging, and it helps us identify those important fibers and important tracks to avoid in surgery. Typically, in surgery, we know where those fibers are, but this technology on the MRI really allows us to help to avoid those important parts. As technology continues to improve, we have more and more minimally invasive techniques. This is a new tool that has been invented it is more of a port system, such as with laparoscopy for general surgery or arthroscopy for orthopedic surgery. This port system allows us to access tumors that are deeper in the brain. And really what it does is it uses this cylinder. Okay, so we push this into the brain. Actually, it splays the fibers out to protect them. And so we can get to the tumor safely, remove the tumor, and then remove the retractor with minimal damage to the surrounding brain. So it's really a novel technology, and it really has been a game changer and allows us to make really small incisions. And you can see the diameter of this is only about 2.5 centimeters. So it allows us to make even smaller incisions than we were just a decade or two ago. After surgery is when, like I said, radiation comes in, and radiation works really in conjunction with surgery. Radiation uses powerful light energy called X-rays or gamma rays to treat the cancer. We have special machines that will make this energy and deliver it in a very precise manner to kill any remaining brain cells. So a lot of technology and even AI is going into this field. And this is where the neurosurgeon typically works with a radiation oncologist to help treat the cancers. Again, radiation damages the tumor's DNA, so cancer cells can't keep reproducing or dividing. And the damage happens directly to the tumor. When treating brain metastasis or even other brain tumors, there's a couple different types of radiation, and the types are not that important, but I will go over them anyway. There are 3 main types. One is the top is conformal radiation, which uses computer images to shape the radiation beams to match the tumor. The second option is IMRT, or intensity modulated radiation therapy, which is a little more refined and adjusts the strength of each beam in order to preserve healthy tissue. So we provide as little collateral damage to the healthy brain. And then the last one is stereotactic radiosurgery, And SRS delivers a very high dose of radiation to a very small area, which also limits any radiation damage to the surrounding structures. And the last one is whole brain radiation therapy, and that's delivered through either conformal or IMRT. And whole brain radiation is actually when the patient has lots of metastatic disease and have multiple tumors, and maybe they're not a surgical candidate. Then we would want to treat all that brain tissue, because we know that if a patient has multiple brain tumors, like 5 or 10 or more, then we would want to treat all the brain tissue, because we know there's cancer in some of the other healthy brain tissue, so we would treat that. We also use whole brain radiation a lot for other primary brain tumors. So we use, and technically speaking, we use multiple beams, but we protect any of the other healthy tissue like the eyes or the skull. And typically, whole brain radiation is given over several weeks. So the value of whole brain radiation helps control cancer in the brain and lowers the chance of new tumors forming. So for some cancers like small cell lung carcinoma, we typically would treat with whole brain radiation prophylactically to make sure that treat the tumors that are there, but also treat any disease that might come around in the future. And like anything, every treatment we have, there's no free lunch. Every treatment we have may have a few side effects. But when looking at the risk-benefit ratio, we always find that the benefit of radiation outweighs any risk that might come along. Stereotactic radiosurgery is something that I use the most with metastatic disease. So when we remove a tumor with surgery, we let the patient's wound heal, and then we work with the radiation therapist to provide a targeted radiation dose. And so oftentimes a patient will have stereotactic radiosurgery. They will get a mask fitted, which will secure their location on the table, and that way when we deliver the radiation, we know the patient's not moving and we can deliver the radiation right to the tumor. Usually this is only over a few treatments, like 1 to 5. And there's a couple different types of stereotactic radiosurgery here. The LINAC-based machines are something that we use in NKC Health. Also, what we're seeing in this picture is a picture of a gamma knife unit, and that actually uses several cells which provide the radiation, and the patient actually does have to wear a frame for these procedures, whereas where we do our LINAC-based stereotactic radiosurgery, the patient just has to wear a mask, so we don't need to do any procedures to put the frame on. But this is another option that you may see at a different center. So if a patient has radiosurgery alone, if they're not a candidate for tumor resection, there's a 50% chance the tumor can come back within 12 months. Because whole brain radiation does have side effects, we now often use stereotactic radiosurgery. And then as far as survival benefit, whole brain and stereotactic radiosurgery have equal survival rates, but the side effects of whole brain radiation are much lower. So now we're going to talk about prognosis. We'll talk about risk stratification and outcomes. And this is where there's lots of promise with brain metastasis. This is a picture of Dr. Patchell. He is famous because he kind of changed the paradigm for treating brain cancers and also treating metastatic disease to the spine. As surgeons, a lot of us know him from his work with spine metastatic disease, but he also had a lot of work with metastatic disease to the brain. And this is where the paradigm really started to shift, where, before his studies in the 80s and 90s, if you had a brain tumor from a lung cancer, then the prognosis was very poor, and we talked to the patients about comfort measures. But now, after his studies, he really found that treating these brain cancers and being very aggressive with surgery and radiation, patients can do very well and actually cure their metastatic disease. They found that patients live longer and have better overall outcomes with surgery and radiation versus just chemotherapy alone. And the other important fact is that adding radiation after surgery really helps control the cancer in the brain. His conclusion was that not all patients with brain metastases have the same prognosis. Obviously, it depends widely on the patient's overall health, their original site of disease, and the how far advanced the cancer is. We have tools to estimate survival for patients. Those tools help us to kind of determine how patients are going to do with treatment, whether it's no surgery or radiation or with surgery and radiation. But that really allows us to tell the patient and the family what to expect. And so we're a lot more precise in saying when a patient has cancer, say, listen, I think you're going to do well. We just need to go through this treatment and you're going to do very well, or vice versa. Ultimately, like most things in healthcare, the overall health of the patient predicts the outcome for all cancers. Patients do better the younger and healthier they are, and the number of tumors that the patient have matter most. So patients with many tumors for lung or skin or kidney cancers tend not to do as well as patients with a single or two solitary metastasis. And then for lung cancer, spreading outside the brain has the biggest impact on recovery and survival. So now I've talked about a little bit about why we do surgery for brain metastasis and the role for radiation, as well as kind of the history and as well as the studies and the prognosis. And now I just want to go over a few cases that we've treated here. Some of these cases have had surgery followed by radiation, and some had radiation to shrink a tumor followed by surgery, and really helped all these diseases. So this first case is a 76-year-old woman with a history of breast cancer. She presented with some weakness on her left side. We can see here from this MRI, these are two sequences of the same MRI. So on the left we see an axial cut, on the right we see a sagittal cut, and right away we can see in the patient's two eyes, their nose, and then right behind the right eye there's a big 3 to 4 centimeter lesion, and you can see all this dark area which is surrounding edema. On this is kind of taking a profile view, so looking at the brain from the side, we can see this big round lesion right behind the right eye and all this swelling and edema. So this patient, because of the size of the tumor and her symptoms and the swelling, we elected to take this patient to surgery to remove the tumor. And so this is just a schematic of what it looks like in the operating room when a patient is going to have surgery like this. The surgery is behind the eyes. We make a vertical incision right in front of the ear. We can open up and see the brain, and typically we can see the tumor right when we open up as well. And so after surgery, we do another MRI to ensure that all the tumor in this area has resolved. And the swelling, one thing you'll notice is the swelling is still there. Well, this image was taken only a couple days after surgery, so the swelling usually will take a few weeks to a few months to completely go away. But you can see where the tumor was, the brain is already filled in quite nicely. A second case that I want to go over is a patient who had single brain met. The patient had, I'm sorry, this is actually for that other case, the first case. The patient had that brain tumor removed after surgery. The patient had stereotactic radiosurgery at NKC Health. And this is the mask that I was talking about. You can see over here, this is a schematic of a patient who had a mask that was fitted for that individual patient. So when we deliver the radiation, the patient cannot move their head, so we know we're delivering it to the tumor bed, and there will be no collateral damage or minimal collateral damage to the other surrounding brain structures. And these masks are quite comfortable, and they're made of plastic, and the patient, during the radiation treatment, only has to lie there for a few minutes. And so this patient got her radiation delivered in 3 sessions. And in preparing for the radiation treatment, the patient had a custom mask made, like I said, and a special CT scan to help fuse that with the MRI. And again, we work closely with the radiation oncologist, and the radiation oncologist here is Dr. Park, and Dr. Park is a great team. And the team is not just Dr. Park. There's physicists and dosimetrists to make sure that the patient is getting the exact treatment and radiation that they need. So it's actually a very big team that they have down in the radiation department to make sure that each patient gets treated appropriately. There's a lot of work that goes into making the plans for the radiation. And this is, I know this might be getting too technical, but this is kind of a radiation plan. So we see the tumor beforehand, so we want to treat the tumor bed, even though she's had surgery. And then this is a kind of a schematic of the radiation. So the red is where all the radiation will be focused. And we notice this, so the red is the hot zone. And we notice that we're delivering this big dose of radiation. So there will be some radiation dose to the surrounding tissue, but it drops off quite quickly. And this green area is the brainstem. So we really don't want to treat that. So we made sure that all the radiation was focused right where the tumor is, and any surrounding structures didn't receive any damage or radiation. This is another case of a patient with multiple brain metastasis. This is a 61-year-old gentleman who is a smoker who came in with some facial numbness and tingling and headaches. We can see on the MRI that he has multiple enhancing lesions. You can see one here. You can see one here with the dark areas to the surrounding edema. He had 6 tumors, and the largest was in the cerebellum, which is in the back part of the brain. His other workup revealed a chest mass, which is about a couple centimeters, but he really didn't have a big chest tumor or a big lung tumor. He presented really with the brain tumors. So a biopsy confirmed the tumor cells in his lungs, and then we went to treatment for his brain metastasis. So what we decided with his multiple brain metastases, when you have multiple brain tumors from your lung that are not, each of them not big enough for surgery, we just elect to choose to treat those with the stereotactic radiosurgery. So we treated those with SRS instead of whole brain radiation because of the side effects of whole brain radiation. And then the patient went on to receive his chemotherapy. And this is, again, just a schematic of this is a cartoon of the patient's head, but you can see the individual tumors that we treated there, and then the big one was in the back of the head called the cerebellum. And again, this is just to show you that the red is the hot spot, and that's where we give the highest dose of radiation, and the green is kind of the dose drop-off, so to make sure that we have as minimal damage to the surrounding structures as possible. This patient in particular showed an excellent response. He had no evidence of new disease after 6 or 7 months. The initial scan is here on the left, and on the right you can see that same slice on an MRI 7 months later, and his tumors have completely gone. So it's a really good result of the radiation. And the last case is a case of a tumor in the back of the head called the cerebellum, and you can see, again, you can see the brain here. This is the front of the head or the nose and the back of the head, and this tumor is kind of right in the middle of the back part of the brain called the cerebellum. This is a 65-year-old woman who was diagnosed with colorectal cancer. She had colon surgery to remove her colon and went through her adjuvant treatments with chemotherapy afterward. Unfortunately, cancer spread to her lungs, liver, and her brain. She initially declined brain surgery, and so we had another option, which was a nice thing. We treated her with radiation. And again, this is a schematic to show you the radiation fields, and it's, like I said, it's really complex, and it takes a big effort on the part of our radiation oncology team to help get these patients safely through radiation. She handled the treatment well and started chemotherapy. And so we can see we followed these patients with serial MRIs after the treatment. So we can see the initial treatment on the left, and 2 months later we noticed that the tumor is getting smaller, and then 6 months after her radiation, the tumor is much, much smaller, and she was feeling much better. And so we keep going out 6 months, we looked at that one, and then 9 months, the tumor continues to get smaller. So the tumor never actually completely went away, and we made a decision about 9 months after treatment that the tumor was never going to completely go away, and that's when we decided to go in and do surgery. And you can see the surgical corridor right here. This is the back part of the brain, so we made an incision here and then removed this bone, took the tumor out, and kind of put the bone back to kind of make sure the patient heals up as best they can. And then the patient had their tumor treated after 9 months after the tumor had shrunk, and so it was a much easier surgery. The patient did very, very well. So those are just a few cases to demonstrate the role of surgery and the role of radiation, and we really work hand in hand. No two tumors are alike. So sometimes the patient gets surgery first, sometimes they get radiation first, and sometimes we do both kind of at the same time. But the nice thing is with the newer technology, with radiation, with other chemotherapy and immunotherapy treatments, patients are living longer, and so patients are doing much better, and we're much more aggressive about treating metastatic disease to the brain than we were just 30 years ago. So again, local treatments help control brain metastasis and improve the quality of life. Patients who are younger and in good health do better, and I think that's true in most parts of healthcare. The type of cancer and the genetics of the cancer matter more now. So when we're taking a biopsy, the pathologists are sending those tumors out for genetic studies because we've learned that genetics matter in treating metastatic disease. Again, we personalize the treatment to every patient, those who get metastatic disease. And then surgery. And surgery is often best for large or symptomatic tumors with a lot of swelling. Or if we need a diagnosis, that's when the role for brain surgery comes in. And then stereotactic radiosurgery works well for as an adjuvant to surgery. Also, it works well for those smaller tumors or tumors that are not surgically accessible. And that's all I have.
Very good. Thank you so much, Dr. Reintjes.
Yeah,
Definitely
my pleasure.
learned a thing or two. It's encouraging to see the advancements and helping patients live longer
Absolutely.
than, like you said, even just 30 years ago. So very interesting. All right, we do have time for a few questions, if you're willing and able
Sure.
here. What are some of the early signs or symptoms that someone might have a brain tumor?
That's a great question. Like I said, no two tumors are the same. So sometimes a patient will, the first sign that they have a brain tumor will actually have a seizure at home. And especially if they don't have a history of seizures and they're older, that seizure kind of means something is going on. So if sometimes a patient has a seizure, they need to present to the hospital, to the emergency department as quickly as possible.
Yes.
Other times, depending on where the tumor is, sometimes they develop weakness in part of their body, or their vision decreases, or their speech decreases, and that kind of tells us what is going on or where the tumor is. And lots of times, like I said, it's not the location of the tumor, the tumor is not causing the problem. It's actually swelling in the brain, which is causing the irritation. And so those are some of the early signs.
Okay, very good. How does a brain tumor typically affect abilities like your memory, speech, or movement? You mentioned the swelling, pushing on those parts. How else does that impact it?
Each area of the brain has a specific, each function of your body has a specific area in the brain. So we know motor function for the right side of my body has a very specific part of my brain on the left side. Same goes for speech. Same goes for vision or smell or personality. And so typically, when one of those is knocked out, that's when we can kind of see, okay, we think the tumor is coming from this area or causing this problem.
Sure. I think you did a great job in your presentation talking about the advancements and all of the new things and how much more precise we are with treatment now. What are some new treatments that you are the most excited about that are headed our way?
So I think the newest thing is personalized treatment. So when we take a piece of tumor from the brain and send it to the pathologist does the traditional stains on it, but also the pathologist takes it and sends it out for molecular studies and genetic studies.
Yes.
So those genetics really tell us, okay, what does the tumor look like at a genetic level, and then that really lets us personalize the treatment. So the surgery and radiation are one part, but then treating the systemic disease with personalized treatment with the chemotherapies and the radiation, those are kind of the most significant things I'm looking forward to, because not all cancers are the same. Lung cancer is not just lung cancer. There's 5 different subtypes or more of lung cancer, but each genetic profile will be different, and sometimes certain treatments will fit that profile better, so we can personalize treatment and give patients better outcome.
Agreed. Yeah, we're leaning into the genetic space a lot in the cancer center side as well.
That's the thing I'm looking forward to the most.
Yeah, very good. Well, thank you again. I appreciate your time today. We hope today's presentation was informative and helpful. NKC Health looks forward to bringing you more insightful and engaging Lunch and Learn presentations soon. Please visit nkchealth.org/class to see our upcoming events. Also, be sure to join us for our next Lunch and Learn, which will be in February, featuring a discussion on heart health led by Dr. Ethan Hacker. Once again, thank you so much for joining us today. Have a great afternoon.